Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. We know that diet-related disease is a big threat to population health. Diabetes, cardiovascular disease, and many cancers all can be attributed in part to things like people's diet quality and their nutrition security. And yet, statements like that, while true, are wholly inadequate. There are numerous other interrelated factors contributing to those and other diseases, and there are also numerous other interrelated factors upstream too, factors as varied as income and environment, and countless other drivers of things like diet quality, which, as we've said, in turn drives health. And so, yes, although we've known about the food and health connection for generations, less clear are how those connections, and there are so many, relate to each other. And also less clear is where someone like a researcher or a policymaker might start when it comes to developing and evaluating interventions aimed at improving diet and health. That's the subject of today's Health Podyssey. I'm here with Dr. Seth A. Berkowitz, a general internist and associate professor of medicine at the University of North Carolina, Chapel Hill. Together with Drs. Hilary Seligman and Darish Mazafarian, Dr. Berkowitz is the co-author of an article titled, quote, "A New Approach to Guide Research and Policy at the Intersection of Income, Food, Nutrition, and Health." It's one of the key framing articles in the brand new April 2025 issue of Health Affairs, which is dedicated entirely to the subject of food and health. This article very much sets the stage so nicely for many of the other empirical studies in the issue, now available at healthaffairs.org. Dr. Seth Berkowitz, we're lucky to have you here to talk about the article. Welcome to a Health Podyssey.
Yeah, thanks for having me on. I really appreciate the opportunity to talk about it.
Great. Well, let's dive right in. Your article offers a quote, new conceptual model for understanding the interrelationships among income, food security, nutrition security, diet quality, and health. Before we talk about the new model, would you paint us a picture of sort of what came before? What was the traditional interpretation of these elements, and where perhaps does it fall short that you felt the need to develop a new model?
Yeah, I think that's a great question. I think in some cases there are, sort of older models that people have, and a new one is trying to supplant it. In this case, I think it's more that there was like a general sort of non-specific sense that these things were kind of related, but there wasn't a lot of specificity to it. And so the newness of this model is trying to add some specificity to these interrelationships. We know overall, I think that, the income you have might affect the food you can buy, and that affects the overall quality of your diet, and that can affect health. But as we've, sort of moved more into this research field, we've realized that, it's actually worth making distinctions between some of these constructs that might tend to blend together, food insecurity as being separate than nutrition insecurity, both of those being separate from diet quality, income, influencing those, income influencing health through other ways that don't go through that. And so our goal in putting the model together wasn't necessarily to say, oh, the old way we thought about these things is wrong, here's a new way to think about it, but rather to say, people are paying attention to these concepts now. They're interrelated. We all know that, but specifically, how does that actually work, and try to give sort of a scaffolding or framework in that sense for people to use as they're thinking about these different interrelated ideas.
Got it. Okay. Well, before we sort of dig into the model, one other background question. I'm wondering if you can say a little bit about why this kind of research is so hard. The sort of obvious example I think about often is, one day you'll read a headline that says, drinking red wine is good for your health. And then the next day it's bad. Same with chocolate. And I think the same also applies to sort of the more complicated dynamics at play here. Is that just the nature of social science and empirical research, or is there something particular about this field that is just really hard?
Yeah, no, I do. I do think there are some elements that are particularly challenging when it comes to nutrition and things like that. I will take a step back and say that I think big picture, when thought about in what I think at least is the right way, or sort of what might be a helpful way, I do think we have pretty sound nutrition science when we talk about overall dietary patterns. Meaning that I think we know overall what are more versus less healthful ways to eat. I think we know that having a higher proportion of your foods come from plants, a higher proportion of the fats that you consume be unsaturated, kind of more fat, plant-derived fats rather than animal fats. I think consuming calories in moderation. I think not consuming too much sugar. I think not consuming too much alcohol. Those kind of big picture things I think are relatively well studied. And we know that there are a couple different dietary patterns that all kind of do that but are helpful. A Mediterranean diet pattern is helpful. A DASH diet pattern is helpful. A lot of traditional patterns from different countries around the world have been studied and found to be helpful. It gets more complicated, as you say, when you start getting into like specific foods or maybe even like specific nutrients. Like, is this one specific food, the best one for you, or are foods with this particular phytochemical good for you, and things like that. That's a little bit trickier and harder to say, as you say. It's definitely the case that in the popular press, because I think we love, everyone loves to eat, and so we love articles about eating and things like that. And so it's always catchy to say, this, do this, eat this one food and you'll live to be 100, or like drop this one food and you'll live to be 100, or whatever else. So that does happen. I think the other thing that's just tricky about like nutrition and diet in general is you're generally talking about exposures that happen over long time frames for their effects to really manifest, years, if not decades, if not, double digit, 20, 30, 40 years, things like that. And that's just scientifically hard to study, right? It's much easier to study something, an antibiotic treats your pneumonia in a week, or it doesn't. And like, that right away versus, a dietary pattern that you have to adhere to for 20 years or something like that. That's just a harder thing to study. I think also just the sheer volume and variety of foods around the world. I mean, I think of blood pressure medicines as a class of drugs where we have a relatively high number of therapeutic agents compared to many things, but that's probably really only like 10 or maybe 15 in widespread use, right? There are thousands, tens of thousands of foods that each have their own, molecular composition, all that stuff. So there's just a lot of variety, and people eat a lot. We're doing it multiple times a day and everything. And so measuring precisely what people are consuming is just sort of a difficult scientific task as well. Multiply that over long periods of time. So I think it is a more difficult area to study in some ways, which adds to some of the complexity around these issues as well.
Yeah, I get that. I keep trying to convince my colleagues at Health Affairs to publish an article about the 10 superfoods that will turn your hair blue or something like that.
Yeah, get those clicks up.
All right. Well, against that backdrop, tell me a little bit about the model in your paper. Can you walk us through it briefly?
Sure. Yeah. So I think the a couple sort of underlying points that we make in trying to relate, and again, I guess it's kind of a mouthful to say all these, but just to say it's a model that relates income, food security, nutrition security, diet quality, and health. So those are sort of the 5 key constructs that we're dealing with. One of the key underlying points is that health itself is a very multidimensional construct. So there's physical health, there's mental health. Even within physical health, there's diabetes and cardiovascular disease. There's kidney disease. There's malignancy and all this kind of thing. So it's a very multidimensional construct. And one of the key things that we wanted to get across is that how these different other constructs, the income, the food insecurity, nutrition security, and diet quality, interact with health has to do a lot with the specific measure or manifestation of health you're talking about. And so there might be, even though both physical health and mental health are 2 key parts of health, diet might have a very different interaction with, some physical health outcomes than other physical health outcomes, or physical health versus mental health and these kinds of things. And so we want to relate that in that sense. The other kind of key thing that we wanted to get across is that, income is sort of this enabling factor that, it provides purchasing power. So it lets people buy various things that they might need to be healthy and can affect their health in different ways. And some of those are food related. And so that's how some of those other things get into. But others have nothing to do with food, right? It lets you buy higher quality housing so you're not exposed to, respiratory pathogens like mold or air pollution. It lets you buy your medicine so you can take those or access higher quality healthcare. It lets you buy transportation so you can get to where you need to be and all those kinds of things. So there are plenty of pathways that income affects health that don't go through any of the kind of nutrition related ideas. And then finally, there are these kind of three distinct but interrelated ideas: food insecurity, nutrition insecurity, and diet quality. The food insecurity, people usually think about as access to the food needed for an active, healthy life. That's sort of a USDA definition of it. It's tightly tied to financial conditions, and so we expect that there's going to be a strong relationship between income and food insecurity. I.e., if you have too little income, you're more likely to be food insecure. We also know that food insecurity is related to diet quality. If you look on average, people with food insecurity have lower diet quality than people who are food secure, probably because healthier foods are more expensive. However, the magnitude of the difference is relatively modest. It's real and measurable and it's persistent over time, but it's not huge. And in the overall U.S. context, we know that there are a lot of things that affect diet quality that aren't related to food insecurity. The overall level of diet quality in the U.S. across all income groups and across both people who experience food insecurity and people who are food secure is relatively low. And so, basically everyone in the U.S., there's probably some room for improvement, or at least every income group and the different food security statuses, there's room for improvement there. So food insecurity isn't the only thing that determines diet quality. And then diet quality, refers to sort of the overall healthfulness of the diets that people are eating. And again, has many influences. So, income and food insecurity are one of those, but there are others, and there are even some paradoxical findings where, for example, in epidemiologic studies, we know that there's greater junk food consumption amongst high-income children than low-income children, which is sort of an opposite pattern of what people might expect. And so we know that there are plenty of other determinants of diet quality that don't go through sort of income and food insecurity and have to do with culture and preferences and the food that's available to us and food marketing and, all those different things there. And then finally, kind of the new kid on the block is nutrition security. And so that's a construct that I think is still kind of taking shape, and what the, final form it takes and how we think about it is a little bit up in the air right now. There's a lot of interest in it. On one hand, we sort of know that some of our traditional measures of food insecurity don't really get at the healthfulness of the foods that people have access to, and so there's some justification for wanting to measure not just do people have access to food overall, but what is the healthfulness of the food that people have access to? And so that's sort of one justification for this idea of nutrition security. Another one is, the diet quality kind of talks about the overall patterns of food that people are eating, but it doesn't necessarily get at what someone's nutritional status is in any given point of time. Do you actually consume enough of the macronutrients and micronutrients that you need to stay healthy? And so another way to think about nutrition security is, as an indicator of the nutritional status that people have. And there are kind of different camps within the field who some prefer this sort of access to healthy food interpretation of nutrition security. Some prefer this nutritional status and overall healthfulness of diets interpretation of it. And so we kind of go into a little bit of these different ideas within this emerging construct of nutrition security as well.
So it sounds like a little bit of what you're getting at is that there are these ideas or factors, but then there's also some complexity around how different people interpret those factors, or I guess the term you use is construction. And so how did you attempt to navigate that tension between sort of the facts of the reality as well as sort of perhaps the nature of the debate around those facts? It seems like you're sort of trying to do both, and it's probably the only way to do it. But I'm curious how you thought about that.
Yeah, no, totally. And I mean, I think there's a tendency in academia overall, and this is probably not a good tendency to, hyper focus on terminology, to make distinctions, even if those distinctions maybe don't have a difference and things like that. And I'm certainly not going to say that we're immune to that or those kind of things, but really the guiding impulse of this kind of work here was for interventional reasons, and in particular saying, because these are different but interrelated constructs, interventions that affect either only one and not the other of these constructs, or affect the constructs to different extents, maybe more of one than another, are likely to have different impacts on health. And so the way we really wanted to sort of organize this approach overall is, in constructing this framework, how might it be used to, one, synthesize sort of existing evidence, make sense of what we know from prior studies, but also provide a way for people to think about, all right, if we want to change health, we want to make people's health better in some ways, which of these different constructs would be the levers that we want to use? And that might be an intervention that focuses only on one. It might be one that tries to synergistically work on multiple ones at the same time. But having a sense of how they're related, we think will let us do better at addressing each of these issues, or at least some of these issues, to improve health. And so that's really sort of the underlying name of the game, is how these might be applied to designing interventions, or understanding, why interventions that have been done had the results they did have.
Well, that's a great segue, going on to interventions. In the paper, you basically sort of catalog a number of different interventions in this space, as well as the evidence about their effectiveness, things as varied as cash assistance on one hand, steps to improve diet quality on the other. I'm curious, as you were looking at those interventions, did you encounter any surprises that maybe caught you off guard?
I don't know if it was so much surprises, but I mean, I think just the variety of different health outcomes that different interventions, saw effects on was really spoke to the sort of the complexity of the situation, but also the potential of using interventions that focus on different constructs within here to achieve different outcomes. Just as kind of an example, for interventions that focus particularly on providing income, but in a relatively unstructured way. So not, saying, oh, you have to use, this income in this way or whatever, but sort of broad income support. We found impacts on mental health. We found impacts on healthcare utilization, like reduced emergency department visits and things like that. But we didn't find as much on, some of the like biomarkers like hemoglobin A1C, for people with diabetes or things like that. On the other hand, some things that were, maybe a little closer on the, on what you might imagine is sort of the causal map between these things. So interventions that are trying to affect diet quality in particular did that, but then they were the ones that impacted some of these biomarkers a little bit more. So we had a food as medicine study that made healthy food more affordable for people with diabetes, and that found a reduction in hemoglobin A1C for people with diabetes. And so it just sort of spoke to the different, aspects of health that you may be able to affect by sort of mixing and matching, so to speak, between which of these different constructs your intervention is targeted towards.
Great. Well, in a moment, I want to ask you a little bit about putting all that into practice. What does it look like to mix and match, if you will? But first, let's take a quick break. And we're back. I'm talking with Dr. Seth Berkowitz about his paper from the April 2025 issue of Health Affairs, offering a new model at the intersection of income, food, nutrition, and health. Okay, let's put this into practice. I'll admit, when I hear the term conceptual model, it feels very academic and theoretical to me. I know that that's intentional. That's the work we do here. But I'm wondering if you can convince me why something like this might be useful in the real world of policy making. Let's say you're in the halls of Congress, your congressman is walking down the hall. You're able to grab him for 60 seconds before he ducks into the cloakroom, and you can put this paper in his hands and tell him why you think it's important for him to know about it. Where do you begin?
So, I mean, I think the real reason that a framework like this is important is because, it helps you home in on the interventional approach that's most likely to achieve the outcome that you want. So again, health is a very multidimensional construct. We can say, yeah, we want to improve health, but your immediate next question after that is like, well, what aspect of health is it? And so from there, that once you've identified that, I want to improve hemoglobin A1C for people with diabetes, or I want to reduce emergency department visits, or I want to improve mental health. Once you've homed in on that, that's when sort of the planning starts, and you say, okay, that's the goal. How do we do that? And I think a model like this is useful because there are all these possible intervention targets. You could try to provide income support. You could try to reduce food insecurity. You could try to provide dietary education and counseling and those kind of things. And you want to have a sense of which one is likely, or what combination of those are likely to achieve the outcome you want. And so that's really where I think the utility is. You have a problem. You want to have, some rational way to come up with an intervention that's likely to improve it. And to do that, we've synthesized a lot of information together that can provide some guidance along the way.
Okay. Certainly for different populations, there are disparities and factors, like you mentioned, income distribution, access to services and supports, even health outcomes. But so give us a picture of what it looks like when you see these factors through an equity lens, and how did you include that in your development of this model?
So, I mean, health equity is really an important topic to all of us, to Hillary and Dari as well. For me, I had a book on health equity come out last year. So, I mean, it's something that I spend a lot of time thinking about, and really sort of informs what we're doing here. For me, the way I think about health inequity as injustice that harms health, and what to me that means is when we have social structures and institutions that sort of aren't providing people with what they need and what they're due as sort of an equal member of society. And we see that play out in a lot of things here. The way that income is distributed in the U.S., the prevalence of food insecurity and the distribution of it, who experiences food insecurity, who has low diet quality, all of that is really patterned by social structures, institutions, practices that distribute resources in the U.S. So, you think of the educational system and whether discrimination and opportunity within that is equally distributed. It's not. And so that leads to, different labor market outcomes with further aspects of discrimination. And all of that might mean that, based on, sort of factors that should not play into this, you see lower income distribution for certain people in the U.S. You see higher risk of food insecurity for people in the U.S. And so thinking about these structures that sort of put people in these positions, I think is really important. And that's why we really in the paper emphasized not only having specific interventions to sort of mitigate the consequences of this, i.e. something that, takes someone who, say, is experiencing, diabetes and, low access to healthy foods and provide, say, a food as medicine intervention to address that, but also at the same time sort of thinking about the structures and sort of background social policies that put people in that situation in the first place. And so that's why you might use income support interventions to provide a baseline of purchasing power for everyone, but then on top of that, add a food as medicine intervention specifically for people who are, in worse circumstances at the present moment. And so we wanted people to think both structurally in a big picture sense, but also be able to think clinically about, say, the patient in front of you if you're a physician, or the client in front of you if you're a human service organization or something like that, and provide specific interventions that way as well.
I wanted to ask about another big factor that we've seen on our radar a fair bit at Health Affairs, relatively new when it comes to food and health, and that's the rapid uptake and embrace of GLP-1s. And let's say that continues to expand and grow. Have you thought about how that fits sort of into this model, or what someone looking at this model might apply to the rise of GLP-1s in healthcare?
Yeah, no, I think GLP-1s are really a very complementary intervention to a lot of the stuff that we're talking about here. So there are a lot of health benefits to GLP-1s, although there's ever more research into the mechanism of action of GLP-1s. A key way that they work is they tend to reduce appetite, and so people tend to lose a good amount of weight while on them. But that weight loss is kind of a blunt instrument in some way. So some of the weight that people lose is adipose tissue, which is endocrinologically active and causes some of the harms of excess adiposity. But some of the tissue that people lose, or some of the weight people lose, is muscle tissue, and so that can cause something called sarcopenia. Too low muscle mass, and that can be associated with frailty and other problems as well. And so having tools that can really cause weight loss like GLP-1s is great, but that doesn't obviate the need for people to consume healthful diets to try to optimize where that weight loss comes from, i.e. can it be more adipose tissue and less muscle tissue when you're losing weight? We also know that at least right now, because of the current patent regimes and everything, GLP-1s are very expensive. And we know that GLP-1s have a lot of side effects, and so there are a number of people who just can't really tolerate being on them. And so I think there are plenty of ways to use nutrition interventions to sort of complement some of that therapy. My co-author, Daria Mozaffarian, had a great viewpoint, I think last year, maybe the year before, about using food as medicine interventions initially while people are on GLP-1s, and then further using it to help people transition off GLP-1s. That time of weight loss might be a time to establish some healthy patterns in terms of how people are eating and things like that. And then ultimately, once a good amount of weight loss has been achieved and everything else, maybe people can stop and maintain a more healthier lifestyle and get sort of the benefits of that treatment, but be assisted by, say, a food as medicine or other kind of nutrition intervention to maintain that weight loss, have healthy diet patterns, and those kinds of things. So I think there are a lot of ways that GLP-1s and food and nutrition interventions can be complementary, but they're also doing different things, and I wouldn't want to have only one or only the other.
Great. Well, that might be a good place to stop. Dr. Seth Berkowitz, thank you so much for taking the time to chat with us today.
Yeah, thanks so much for having me on.
To our listeners and our readers, check out Dr. Berkowitz's article in the April 2025 issue of Health Affairs. And if you enjoyed this podcast, please recommend it to a friend, smash that subscribe button, and tune in next week. Take care, all.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about the Health Podyssey.